Hello, my colleagues, my friends from Malaysia. I'm Renato. I'm speaking from Brazil. And today we're going to talk about a video head and pulse test. It's a very important test for everybody who wants to learn more about neurology and who wants to, help these patients around the world. So it's fundamental that we understand the basis and the physiology of the test. I'm going to share my screen here. Um, Okay, I hope you guys are seeing that. Okay, so we're gonna talk about the head impulse test, the video head impulse test, and I'm gonna go through what we need to know about it. What is the important features about this test? Um, I have a few disclosures here. I work as a paid speaker for a few pharmaceutical companies around the world, and I'm a shareholder of GSK, and I got some free devices for beta testing from Natus and also from Interacoustics. What is the outline? What is the outline of this talk? We're gonna go through general information about the video head impulse systems, and we're going to talk about physiology of the VOR, which I really believe that's the most important part of the talk. And we're going to go through some kind of different kinds of VOR gain calculation because the devices use different ways of calculate the gain. So when we go back in time, we need to remember that Professor Robert Barney, back in 1906, he described for the first time what we call today as caloric test. And caloric test was for many, many, many years like the gold standard for evaluating the vestibular functioning, right? And this is the original paper Professor Barney published in 1907, and it was the reason that he got a Nobel Prize for that in 1915. And during the war, I mean, Professor Barney, he was actually a prisoner of the Russian emperor in 1915, and he got an agreement between the Prince of Sweden and the Czar in Russia, and he was released and he got his Nobel Prize in 1915 for the description of the caloric test. And the point is, from 1906 until today, we still having caloric tests. And let's think about today. We got some major companies like Google, Facebook, Amazon, Apple, and we got the United States as a great economy in the world. We have China coming on. We have such politicians in Russia, politicians in America, politicians in Brazil. We got new politicians in America. We got a tragic split in British Empire. We got Brazil takes off. We had Brazil blow it. We got coronavirus, and hopefully we got vaccine for coronavirus. And all this change around the world, we're still doing caloric tests. And this is the funny part because we still, throwing water or air into the patient ears, and the patient is still getting sick during the test. They just hate it, and we are doing that. So I got a few warning before we're gonna go talk about any kind of vestibular test. To be honest, it doesn't really matter if you have a very fancy video nystagmography system or if you have a TRV chair, which is fantastic for treating BPPV. This is myself in South Korea a couple years ago testing with Professor Thomas Richard Vuitton and Professor Alexander Guzevan from Russia. And it doesn't really matter if you have a Vhit or if you have an Orion rotary chair or if you have a Porsche platform. It's a wonderful Porsche platform, but it's actually it's a mission impossible if you believe that you're gonna diagnose your dizzy patients just performing tests. I have a mentor back in the United States, Professor Stephen Rauch, and from Boston, and he used to say that if you see a dizzy patient and you send this patient to a vestibular lab with no idea about the diagnosis, the test will give you no diagnosis. It's like the same thing to send a patient to the radiology and tell the radiology guy, say, well, the patient's sick, please scan. So what is the chance that he's gonna find a disease? It's much lower. So vestibular tests, any tests, they have 4 big problems, right? And first problem is that none of the vestibular tests evaluate the 5 end organs, right? I mean, the 3 semicircular canal crystals and the sacral and the utricle macula. So there's no test that you evaluate these 5 organs. You have head impulse that you can evaluate the crystals of the semicircular canals. You have the vamps, the O vamp and the C vamp that you can evaluate sacral and utricle, but that's not a single test and you can go through all the end organs in labyrinths. Second problem is that the labyrinth tests, the vestibular test tests the labyrinth in such an indirect way, which means you are not testing the labyrinth, you are testing responses from the eyes or from the muscles, and these responses are originating labyrinth, but you're not testing itself, I mean, directly. So this is a problem. Another problem is those tests, they are tests of functioning. I mean, what information a vestibular test can tell you? It can tell you that your labyrinth's okay, it's not okay, or it's more or less. But that's just like that. If you are hoping that your vestibular test will tell, oh, this patient has Meniere's, this patient has vestibular neuritis or BPPV, you can forget about that because the test will not give you that. They give you absolutely no diagnosis. So this is a thing that we supposed to keep in our minds all the time. And to talk about the video head impulse test, we need to remember the clinical head impulse test. And the clinical head impulse test was described by Professor Halmagyi and Courtois more than 30 years ago. Those are the guys who are describing the test. Great research, great clinicians. And the basis of the clinical head impulse test is performing a head impulse, and you ask the patient to keep their eyes in target. And you see this is Dr. Tissa van Duren from Netherlands. He's a friend of us, and he's our volunteer. And you see she got a normal VOR response in both sides. This is a patient with a left side vestibular hypofunctioning. So, oops, you move the head to the left and you see a saccade. The right side seems okay. Left side broke. This is a patient with a right side vestibular hypofunctioning. Oops, right side's broke, left side's okay. And this is a patient with bilateral vestibular loss. So right side's damaged and left side is also damaged. So this is the clinical head impulse test. This is what Dr. Halmagyi and Courtois described back in 1988. Well, this is such a great test. It's great bedside test, but it does have some limitations. And what is the limitations of the clinical head impulse? First of all, it's a subjective test, which means it depends the ability of the physician to understand the test and to evaluate the result. So it's a subjective test. Second limitation, it's very hard to test the vertical canals. I mean, you can do that, you can do like head impulse in vertical canals, but it's not so easy to understand that. So it's a kind of limitation. And this is probably the main limitation. The sensitivity of the clinical head impulse test not that high. I mean, it's about 50%. And it's basically because of the covert saccades. Because the covert saccades, there are saccades that happen while you're moving your head. Our naked eye cannot see the saccades. So this is what drops the sensitivity of the test for about 50% according to the, some literature. And this is not a quantitative test, which means you do a test and you see, okay, right side's damaged, but you have no idea how much it's damaged. So it's a qualitative test, not a quantitative test. And it's hard to record. I mean, you can keep your iPhone over here and do the test, but it's not the best way to record that. So those are the limitations for the clinical head impulse test. And that's the reason we have right now the video head impulse test. And the video head impulse tests are devices that evaluate your VOR gain, right, in 3 semicircular canals in each side. And at some point back in time, the only way to evaluate the VOR gain before the video oculography devices were what we call the scleral search coil method. And the coil method You have a few advantages like lightweight, high temporal resolution, accurate and precise, minimal slippage. But you have many disadvantages, like it's an invasive test, you affect some saccades dynamics, the measured time is limited because the patients cannot keep the coil in their eyes for many time, and this test is clinically unfeasible. So we are not doing scleral search coil in our daily basis practice because it's not feasible. And right now we have what we call the video oculography system, right? And when they describe the system for the first time, they need to do some kind of comparison between the coil and the devices. And this comparison has been publicating back in 2009 in many different research, many different journals. This is a neurology journal showing that and that the head impulse is equivalent to the search coil we identify peripheral vestibular deficits. It's been published in PLOS One journal. It's been published in Otology Neurotology by the Johns Hopkins group. It's been published in Annals of the New York Academy of Science in 2009 as well by Sydney group. So it has been done. I mean, we are pretty much sure that right now the video oculography devices, they are actually represented the VOR functioning. And you have many different systems available worldwide. I believe the most common one are the IC-CAN from Interacoustics and ICS Impulse from formerly Autometrics and now Natus. And what these devices do exactly? Here's an example. So you have a patient, you move the head to the right, you have a plot showing the head and the eyes to the left, and you do that many times. And this is what the system does. I mean, it analyzes the head movement and the eye movements, and you can do some kind of comparison about how much the head goes to the side and the eyes goes to another side, and this is what it does. And for the native system, it's basically the same thing. I mean, you have the eyes and the eyes in different positions, but the difference because the software display just flip the image and you have a result like that, which is actually the same of this. So when you see this plot here, it's exactly the same of this one, just in different systems, okay? So one of the advantages of the video head impulse test, because you are actually testing your vestibular functioning in a such high frequency, much more high than caloric tests, which is being described in the last century. Why do we have semicircular canals? Semicircular canals, we have to, giving information to the brain about our angular acceleration. And when we move our head in a daily basis life, we move our head in such a high frequency. And that's the physiology frequency. And that's exactly what the head impulse test does. Analyze the VOR in such high frequency. What are such benefits for the video head impulse? It's a simple test, it's quick, and it's a basically non-expensive test. You can test 3 different semicircular canals in both nerves, I mean superior vestibular nerve and inferior vestibular nerve. It's different in calorics because calorics you test just lateral semicircular canals and just superior branch of the vestibular nerve. It's comfortable for the patient. I mean, the patients, they do not feel dizzy, they do not feel uncomfortable. So it's very feasible to do the test. I mean, the patients do not be angry by throwing water in their ears. It has a test and retest reliability, which is great. I mean, you can have one patient and you do many times the same test and you're going to have the same results. Does not require any kind of preparation for the test. You use a physiological stimulus, which is basically the head movements. It's a test that uses your physiological frequency that move in the head. You can test how many times you want. I mean, it's good when you have patients with vestibular neuritis, you can do tests in the acute phase in 1 week and 1 month, in 3 months, and you can do many times. The patient will not complain about that. But there's 3 things that we need to be aware about the video head impulse. One is the physiology of the VOR to understand the test. You just need training to do the test. It's not a plug and play system. I mean, it's required, you have a learning curve to do a very good test, and you must understand a little bit about artifacts. I mean, video head impulse not it's not a artifact free, which means you got many of those, and you need to understand, you need to know the artifacts and to be aware how much it could have some kind of influence in your outcome or not. And to avoid the artifacts, calibration is one of the parts that are major important in this test. So let's talk a little bit about physiology, because I believe physiology is the most important part of the test. So we talk many times about VOR gain. And what about this VOR gain? What is VOR gain? And when we move our head to the right side or left side, my eyes goes in exactly different directions, but with the same velocity and the same, you know, distance. So we can have some kind of definition of the VOR gain, the relation between eye movement and the head movements. And if my head moves 30 degrees to the left, my eyes will move 30 degrees to the right. And if my head moves 100 degrees per second to the right, my eyes will move 100 degrees per second to the left. So the relation between hand movement and eye movement in a normal condition, it's one. So the physiology of the VOR gain, I mean, the normal patients in the physiology, the gain of the VOR is supposed to be one, right? So if you do this relation between eye and head positioning, the VOR gain is supposed to be one. Okay, so let's imagine this patient here. It's a normal patient, no vestibular deficits, and the patient moved the head to the right. So if I move my head to the right, I got some stimulus in the right side semicircular canal. I know that even when we are relaxing our labyrinth, we do have some neuroactivity, and this neuroactivity is about 100 degrees per second. I mean, the spikes per second. And when I move my head to the right, let's imagine that I move in such a not so fast velocity, and this stimulus in the right side is increased for 100 spikes per second to 200 spikes per second. So I increase the neuroactivity in the right side. But if I move to the right, I increase the right side, but I decrease the activity in the left side, and in the same proportion. So the activity in the left side was 100 spikes per second, so it decreased to zero. So the information that comes from my VOR is the sum of the increase and the decrease activity. So this is a graph, a positional graph, and this is a velocity graph. So black is head velocity, green is eye velocity. So I moved the head to the right, but the eyes were to the left, and in the same velocity, normal patient, and in position, and same position. So it's everything, it's okay here in normal patient. Now, imagine that you are performing an impulse. I mean, in a very fast impulse. So I move my head to the right, very fast. So I have an increase of activity from 100 to 300 milliseconds, but the decrease in the left side, it just can drop to zero. I mean, it cannot be negative. So you have some kind of asymmetry of the information that goes for your VOR. So that's the reason when you do a very fast impulse, your VOR gain, maybe it's not one, maybe it's like 0.8 or 0.9. And the reason for that, it's according to the head velocity. When you do a very fast impulse, your VOR gain drops a little bit because the inhibitory side, it just comes to zero and it cannot go below zero. So the information is a little bit asymmetry. And this is the reason that the VOR gain is not one. And most part of the systems, I mean, interacoustics and natos, they using the normal parameters from VOR gain from 0.8 to 1 as normal. So when you have like a plot like that, you see these micro saccades here. And this is physiological saccades because you had a very fast impulse, and these saccades are just physiological because the gain here it's about zero 0.8 or zero 0.9, right? So this is, the position is not exactly the same, so you need a microsaccade to correct that. This is a normal Vhit in a high velocity. So let's imagine right now a pathological situation. This is a patient with right side damage, right? So right side, I move the head to the right, to the damaged side. So I will have no stimulus in the right side because it's damaged. But I will have some kind of inhibition in the left side because the left side is okay. So the VOR gain will not be zero as I expect because I got a complete lesion in the right side. The gain will be like, I don't know, 0.4, 0.3, because this gain here is based on the inhibitory side. And right now, you have a patient with a right side damage, and you move your head to the left, which is normal side. You do have the excitatory in the left, but you do not have the inhibition in the right. So that's the reason the VOR gain, even though in the normal side, will not be normal. I mean, will be a little bit down, like 0.7 or maybe 0.65 or something like that, because you do not have the inhibitory response. So here you understand a very important thing. Video head impulse test, you're not isolate one side. So when I move my head, I always test both sides. I have an excitatory response, but I have an inhibitory response. So it's different than caloric because caloric, you test just one side. And head impulse, you got some influence from the other side that you are not testing. And you need to be aware of that to understand the results. What about saccades? What is saccades? Saccades are fast, precise eye movements that are being made as reflexive to correct a deficit in your VOR gain. So let's imagine here. You move your head to one side, your eyes come here, right? There's a difference between head movement and eye movement, so your brainstem trigger a saccade just to correct this different in position. So this is a positional plot, this is a velocity plot. So here's the head, here's the eye velocity, and here's the what we call over saccades. And why we call over saccades? We call over saccades because the saccades happen after the finish of the head movements. And the latency for over saccades, it's about 100 milliseconds after the head movement stops, right? And why it took like 100 milliseconds? Because if you go to physiology, you have to remember that the latency of the VOR, it's about 8 milliseconds because VOR, it's a very fast stimulus that comes from the labyrinth to the vestibular nuclei, to the ocular motor nuclei, and to the muscles and to the eyes. So it's a very fast phase. And when you have a saccade, the input of the saccade is visual. So you need to come from your eyes, go to your cortex, go to your brainstem, cerebellum, vestibular nuclei, ocular motor nuclei, and then go to the eye. So this trajectory here takes about 100 milliseconds, much more slower than VOR reflex latency. So when you do a clinical head impulse test, like in this patient here, look at that. Oops, you see a saccade. This saccade that you see, it's what we call over saccades because it took more than 100 milliseconds for you to trigger that and your naked eye can see. But back in 2008, when Professor Hamag and Courtois, they were developing the video head impulse system, they just realized that we have another kind of saccades that we call cover saccades. And what is cover saccades? Cover saccades, it's a one saccade that is triggered while you are moving your head. So your head is moving here, your eyes moving here, your eye stops, your brainstem just recognize that it's not matching. So you trigger a saccade while your head is moving, then your head stops and you have another saccade. So this saccade here that happens while you are moving your head, this is what we call cover saccades. And our naked eye cannot see that. So that's the reason we need a system of the video head impulse system to see the saccades, right? And these saccades, the cover saccades that happen while you're moving your head, those are the reasons for the low sensitivity of the clinical head impulse test. This is a video from Professor Karambarin from Ohio, and he's a great friend of mine. He gave me this video here, and it's a very good video to illustrate what is cover saccades. Let's pay attention in this video, this side here. Look at that. The patient's moving to the right. Look at that. Oops, there's a saccade. So you realize that this patient has a right side damage. And left side seems okay. Right. Let's pay attention. This move here. Look at that. He moves to the right. Seems normal, right? And he moves to the left. Seems normal. Okay, so if you do a head impulse in this patient, you think that this is a normal VOR gain. So right now, let's see the same patient in a very slow motion, like frame by frame. Look at that, moving to the right, the eyes there, moving to the right, look at that, oops, and keep moving to the right. So what you saw? You saw a cover saccade. You saw a saccade that happened while you're moving your hand. And this saccade you're not be able to see before, right? So this is what we call cover saccades. It's very important to everybody to understand the difference between cover and over saccades. What about the VOR gain calculation? You know, calculation of the VOR gain is not an easy job at all. And different systems use different technologies to calculate the VOR gain. For example, there are basically 3 different types of gain calculation. First one is based on velocity, eye velocity and head velocity. Second one is based on area or positioning. And the third one is what we call regression methods. So the velocity method it's used in ICCAN for interacoustics, and it gives you different velocity in different times, like 40 and 60 and 8 milliseconds. So you see the different velocity between head and eye in different latency, and give you different VOR gains according to the latency. This method, you have some advantages over the area, just because you got no influence from the cover saccades, but you have some disadvantages because it's much more sensitive for goggle slippage, and you have this different, advantage and disadvantage method. And when we talk about area, it's a calculation the area below the head and the eye movement, right? And here's different position here. So this is a very good method, but you does have some disadvantages as well, especially when you have cover saccades, because the software, it has to identify the cover saccade and excludes the cover saccade area to not get any influence in the VOR gain. One of the advantages of this method is because you got less influence of the goggle slippage, but you are more sensitive for pupil tracking deficits. So both methods are okay, both methods are good, but they're not perfect. And look at that, you have to exclude the cover saccades to not get any kind of influence in the VOR gain. And the regression method, it's a robust way to calculate VOR gain because it calculates the mean of the all impulses in the first 100 milliseconds. You have the same advantage of the velocity, right? And you can use the regression method as well to be aware about the VOR gain. So my point is, different devices use different methods. There are no perfect method. Each of them has advantages and disadvantages. So you need to be aware about what kind of device you are using and to understand this difference. One of the good things about the video head impulse test, different in caloric tests, because you have the chance to evaluate the vertical semicircular canals. I mean, caloric test allows you to evaluate the rotary chair test, you evaluate the lateral semicircular canals, but the video head impulse gives you the chance to evaluate the vertical, anterior, and posterior canal and the lateral canal. So you can evaluate all 6 semicircular canals. And I want to show you how the importance of those in a clinical, in a real case. Pay attention in this patient. It's a young boy, and he got a vertical attack. And here, with the eyes open, you see no nystagmus at all, right? And when I shut his eyes, some nystagmus start to appear, right? Look at that. He start having a left beating nystagmus, which is expecting in right side vestibular hypofunctioning. So he got a left beating nystagmus here with the eyes shut. And if you do a head impulse, right side is damaging, left side is okay, right? And when you do the video head impulse test, you can be aware that the left side is all okay, but the right side you have damage in anterior canal, in lateral canal, but posterior canal is perfectly fine. So it gives me the topography of the lesion. I mean, the lesion, it's located in the superior branch of the vestibular nerve, in the right side vestibular nerve. And this patient I reevaluate after 12 days. And look at that. After 12 days, he got no nystagmus with the eyes open. Of course, I start steroids and vestibular rehab, and the patient was much better, right? So with the eyes shut, you see no nystagmus after 12 days, which is good. And the head impulse, the clinical head impulse was quite normal, right, to the right and to the damage. But when I see the video head impulse test, the VOR gain the left in the right lateral canal is still pretty bad. I mean, the gain, but the behavior of the saccades were different. And that's a paper I wanted to highlight you from Professor Nicolas Perez and Angel Gatuecas and Jorge Ray Martinez. Those guys are great research from Spain, and they just published this paper that they developed what we call PR score. It's Perez and Ray Martinez score. And this score is a way to calculate the behavior of the saccades. And this score goes from 0 to 100, and when it's close to 0, it means that the saccades are gathering, and when it's close to 100, it means that the saccades are scattering. So look at that. The patient in the onset day, he got a VOR gain 0.5. After 12 days, the patient was much better, but the gain is still pretty bad, like 0.5. But the saccades were absolutely different. In the first day, the saccades were pretty much scattering, pretty much based in over saccades. And after 12 days, the saccades just gathering and become much more cover. So it's a kind of example of how you behavior with your, as long as you compensate how the saccades change. And after 4 days, I mean, a couple months after the attack, the patient, I mean, he got, of course, no spontaneous nystagmus, even with the eyes open and with the eyes shut. I mean, no nystagmus at all. Eyes shut, you see no nystagmus, perfectly fine. And look at the VOR gain, it becomes like 0.9, so they regain to the normal. And here's what I showed to you that. In the acute onset, VOR gain was 0.5 and the PR score was 100, so the saccades were much more scattering. After 12 days, the VOR gain is still 0.5, but the PR score drops to 6, so the behavior of the saccades change. And after 4 days, the VOR gain was normal. So I can tell you that after 12 days, the patient was partially compensate, and after 2 months, he just recovered the function of the vestibular nerve. So right now, I use it to tell my residents and my fellows that much important than the VOR gain is the saccades. I mean, saccades are very important to analyze the behavior in the video head impulse, maybe much more than the VOR gain. You see here, the gain is normal. The gain is not normal, but similar, but the behavior of the saccades are quite different. And it gives you a lot of information about the compensation process and how the patient is doing. So the good news about the video head impulse test, because you have different tests that you can do that. And with the Vhit device, you can do the HIMP, the head impulse, you can do the SHIMP. I'm not go through the SHIMP right now in this talk because I don't want to run out of time. But you can also perform the VVOR and the VOR test that we talked yesterday. So those are the good news. You have a pretty good device that can do different tests. So thank you very much for having me here. It's a pleasure to be here with my Malaysian friends. And here's my personal email, so you can email me any comment, any criticism, any suggestion. Please let me know. I'll be happy to answer that. Thank you very much, my friends. I really appreciate that. Thank you very much.